Good morning, everyone. I have created this video to review some of our current initiatives to decrease surgical site infections and review why they have been initiated. And the first initiative that I'm going to talk through is the wound consult that we are placing to our wound RNs in the system. This process was actually started back in June of 2020, and we started this initiative as a result of a large number of readmissions for infections. Since we have initiated this, we have actually seen a decrease in SSIs, and I just want to reintroduce the process and ensure that everyone is on the same page, because there has been lots of questions regarding the process and when a consult is needed versus when it's not. The reason why we have initiated this is so that the wound RNs can come in proactively and reiterate the education that we are already touching on. So just to give a little background, anytime a patient develops a surgical site infection following discharge, the leadership team does a deep dive into that patient's chart to look at what can be changed, what needs to be improved, and actually identify if the infection was preventable, so that we can improve patient outcomes in patients to come. Through this deep dive process, we have noticed that there is a recurrence of the wound consult not being initiated for patients that meet that specific high-risk criteria, which I'm going to go over shortly. But I just want to point out that surgical site infections actually can develop in about 1 to 3 out of every 100 patients that have surgery. We do an average of 2,000 C-sections per year just on this campus, and we have seen a decrease in surgical site infections since we started this process, and we want to ensure that patients are receiving multiple avenues of information prior to going home to decrease our chance of readmission to the hospital. So the current high-risk criteria that we have outlined includes BMI greater than 30, if they are a smoker, a diabetic, if they have current open incision, if they have a current wound infection, any history of MRSA, history or current drug use, if they are immunocompromised, or if they have an autoimmune disorder. We do have a high volume of C-section deliveries, and it is not our goal to inundate the wound care nurses while they're also trying to maintain their current other wound consults that they are doing for patients throughout the specific high-risk criteria should be used as a guideline to consult, not as a requirement. Use your nursing judgment based on your assessment of the patient's incision, their history, and environment that they live in. So I'm going to give a couple examples. A patient who has a BMI of 35 but is 6 feet tall does not need to have a wound consult placed, because there's a probability that that patient does not have a large abdominal fold. If she has good self-care and hygiene and is eager to learn about wound care, then this patient is not required to have a wound consult placed. However, the chart should be convincing in that every initiative that we have set, for example, patient has viewed the Get Well Network discharge video, our C-section and care video, and all of our education pieces are documented, and as the patient has had a shower daily and linen changes daily, then it's not needed for this patient to be seen by the wound nurses. On the other end of the spectrum, if we have a patient that has a BMI of 45 and is a diabetic, her wound healing process is not going to be great. So if we can get that patient more information from the wound nurses, that is our goal prior to them going home. So our goal would be for the nurses to place the consult at 24 hours from the time of delivery, ensure that the patient is showered and the abdominal bandage has been removed so that the infection nurses are able to visualize the incision. So just to reiterate, a wound ostomy nurse eval and treat consult should be placed with an EPIC for anyone meeting the high risk of infection criteria based on your nursing judgment. That includes anyone with a BMI greater than 30, smokers, diabetics, anyone with a current open incision, a current wound infection, if they have a history of MRSA, have a history or current drug abuse, have poor self-care, if they're immunocompromised, or has an autoimmune disorder. ladies, I am here with Charlene and Jessica. They are our wound care nurses here at Norton Women's and Children's, and we just wanted to talk through one of our initiatives that we have set for our unit to decrease surgical site infections. Charlene's going to talk a little bit about what she speaks to the patients about as far as education and care for when they go home.
To them about how that is a warm, moist area underneath there, and some women, may have a little bit more tissue down there on their belly than other women, so they'll have more covering, so they just have to watch that. And so that's when you use the Inner-Dry, and I ask them if they have ever heard of that, and I let them feel it and say, this is what we use. It's kind of like an Under Armour material that wicks away moisture, and then they get it. It's like, you just got to kind of relate it. Whenever I open it up, I tell them I pull it out, because this is the biggest thing. You want to go this way to show them the length they should have. It should be the length of their abdomen. And I always cut a strip and try to place it myself and clean it unless they tell me they were getting ready to shower. And then I go ahead and cut this for them with clean scissors. Tell them that too. It's got to have clean scissors. And cut it the lengthwise. And then they want to fold it in half like this. So they need it to length of their abdomen, to put under some stretch panties, and tell them to always have the clean panties, because that's another big thing. And they can use their own or whatever they want to use, but that just holds that in place. And so I leave both of those for them. That we use the Dial Gold soap, and I tell them they can purchase that anywhere. It can be a generic form if they can find it, and to lightly cleanse that with clean cloths all the time. That is the biggest thing, is that it always has to be a clean cloth. They don't want to scrub the area. They don't want to put any lotions or ointments on that area, because it can open that wound. Tell them to look for infection like redness, swelling. Are you running a temperature? And then they should be calling their OB. And tell them that if they have any drainage that is has any pus in it, or even a foul smell from the wound itself or from the vagina, because we have to think of this is all connected. So you have to really talk to them about that. Then they should be calling the doctor. And, if they do notice that there is an opening in that incision, they should call the doctor also, because we don't want that to open up. That could cause a bigger infection. And then that leads me into asking them if they were a gestational diabetic. And if they answer yes, then I say, well, I'll put further information in your chart about your diet, because that'll take away some of the carbs you want to eat, because you want to get your body healthy again. And that we recommend 30 grams of protein, and they can get that from lean meats, chicken, any kind of beans or fish. They also can get that in drinks, because they're busy, they got a baby, or maybe they're just tired, and they can drink 30 grams of protein in a shake. But they need to get that protein to heal. They don't understand it's a healing thing. And that's pretty much it. And then I tell them that it is beneficial with the protein also for breastfeeding moms, and that it helps them, so that brings them in with their baby. You all can always call us too. Don't forget, if you have questions, you can call and ask, and we might be able to help you right over the phone. Okay, so there you go. That's my spiel.
This slide reviews proper documentation of incisions and wound care. The top row includes site assessment, closure, and margins. Each of these should only be documented when you can see the site. Just remember, you should only be documenting what you see, not what someone else documented prior. Please be sure to document all dressing changes if applicable. This also includes steri strips and proxy strip replacement. Please remember to give all C-section patients the C-section home care kit at discharge when you are reviewing their AVS. This kit contains Dial soap and specific instructions on how to clean their incision, as well as when to call the doctor. Additionally, their AVS has more detailed instructions on restrictions. Please ensure you are documenting this in your discharge note that the patient received this kit. So this final slide covers additional information that is important for staff to know, including our goal of the teach back, show back method for incision care, as well as having the patient watch the Get Well Network C-section video prior to discharge. Before they are discharged, please ensure that it is documented within the education tab that they have completed the video and state understanding. Please ensure that the patient is only using the designated ice packs for an incision, not using the peri ice packs, and ensuring that the ice pack does not go into the pantry room. Instead, a cup of ice should be taken to the patient's room to refill the ice pack. And finally, please ensure every patient is receiving a daily shower and linen changes. Please elevate your concerns to the A&M or manager if the patient refuses to shower or have a linen change.